You're listening to the ATS Breathe Easy podcast, brought to you by the American Thoracic Society.
Hello and welcome. You are listening to the ATS Breathe Easy podcast with me, your host, Dr. Eddie Qian. Each Tuesday of every month, the ATS will welcome guests who will share the latest news in pulmonary, critical care, and sleep medicine. Whether you're a patient advocate, or healthcare professional, the ATS Breathe Easy podcast is for you. Joining me today is Dr. Matthew Churpek, who will continue on our prior discussion about AI, but this time we'll talk about its role in clinical practice. Dr. Churpek is faculty in the Division of Allergy, Pulmonary, and Critical Care Medicine at the University of Wisconsin. He's quadruple board certified in internal medicine, pulmonary medicine, critical care medicine, and clinical informatics. In terms of research, Dr. Churpek's data science lab utilizes electronic health record data and machine learning techniques, such as natural language processing and deep learning, to identify patients at risk for clinical deterioration, sepsis, AKI, and other syndromes of critical illness. He's recognized for this research by the ATS and the ASCI. Matt, thank you so much for joining us. Do you have anything you want to say before we jump into it?
Yeah, I just wanted to say thank you for the kind introduction and thanks for having me.
Thank you for joining us, Matt. I really appreciate all the time. And like I said, you just seem to have a lot of busy research going on. Like I said before in the intro, we've talked about AI on this podcast and the scientific writing process, but a topic on so many minds is AI in clinical practice. Like, how is this going to impact our care for patients, both from a healthcare provider side, and then for patients, how is AI impacting their personal care? In some form, AI has been present in medicine for many years, even though it seems like that it's only exploded into our and the general public's consciousness over the past few years. Matt, first, let's start from the beginning. Can you give me some examples of products that you know that have been powered by machine learning and clinicians have already been using to take care of patients for many years?
Yeah, I think, AI there has been an explosion of interest in AI, both in, in the private sector and also as it relates to clinical medicine. And, as you mentioned in the beginning, AI is really a way to essentially have machines automate things that we think of are associated with human intelligence. So, decades and decades ago, AI systems were developed where experts would develop these rule systems. For example, one from 50 years ago now was ID clinicians would generate hundreds of rules around how can you identify if a patient has a bacterial infection, and then can we recommend antibiotics? But I think similarly, if you think about whether it's clinical medicine or, trying to teach a car to drive itself, the rules start breaking down because they become so complex and there's so many exceptions. And that's really where machine learning has, come into play. And I think now what we're seeing are these tools where you have machine learning models learning from lots and lots of data, and these patterns are then identified that then can help clinicians. And so when we think about the types of products that have been around for a while are those where there are a lot of training data available. So think about radiology images, for example. There have been AI tools around for many years that will do things from improving the image quality to segmenting parts of the image, to identifying things like nodules, or help identify other aspects, or even today now, essentially providing a preliminary read for the image. So I think radiology is one area where we've seen some of these systems already available. And I think we're going to see more and more of these systems to come.
Yeah, so much of when we're talking about teaching clinicians, residents, and medical students, we say, the patients don't always walk out of the textbook just saying that there's so many different ways that people can present. And so recognizing all these patterns and stating rules for all these patterns is just an overwhelming proposition, obviously. But what, Matt, I've referenced that you've done a lot of research in this already. What are some examples of some projects that you've been working on in the past that are in this field that clinicians might already be using and not realize they're listening to the person who developed it?
Yeah, so the research that I've been involved with for over a decade now relates to early warning scores. So the idea that you have these patients who are out on the general medical surgical wards, and Some of them, most of them are going to get better and, eventually leave the hospital. But there are some of them who are going to deteriorate and potentially ICU level care. They may suffer a cardiac arrest or have other adverse outcomes. So for many, many years, groups have developed these tools that were based on expert opinion around how can we identify these patients. And so a project that I worked on during my residency and then into my PhD, and I continue to work on now, relates to developing machine learning versions of these tools, where what we've been doing is we use patient-level data and machine learning models to identify these patients earlier. And then if you can identify them earlier, you can get the critical care resources to the bedside of the patients. And then hopefully by doing that, you can get better decisions, earlier transfer to the ICU, and potentially better outcomes for our patients. And I think when I first started this work, this is when electronic health records started becoming more common across the country. And at that point, the difficult thing was even getting access to the data. And then once you had access to the data, you were using methods that were developed, 50 or 100 years ago, is simple logistic regression or these other simpler machine learning algorithms. And often you're just working with vital signs and laboratory data and maybe a few other variables. And so as you mentioned at the beginning, I think we've really changed machine learning itself has changed a lot in terms of how we think about its use in clinical medicine. And I think that's why it's really exciting to think about the future of going from not even being able to access the data to now having lots of data available to really train these models and to learn how to better patient care.
Other than data, how have things changed over time, either from the access to the data, the algorithms that we're using, developments in the field? We're in a very different place than we were 10, 20 years ago. So what kind of changes have you seen over your career?
So I think we think about maybe the algorithms first. I think that AI in general, right? It's a lot of what we saw at the beginning again were these expert rule-based systems, and then in came machine learning when we were able to essentially collect and learn from these data. And then over the past several years now, we've moved from then deep learning, which is a type of machine learning, into then large language models, and then into generative AI, where instead of saying, tell me the probability that this patient has, is going to need the ICU in the next 12 hours, we're now having, review the medical literature on this topic, or providing examples of complex patients and having it output, text for us. So I think, things have changed quite a bit on the algorithm side. I think in addition to that, and then the availability of data, and I think in the way that we've had more efficient, computer chips and computer algorithms. I think the other thing that's changing that I think is really important is the fact that we as users of AI are becoming a lot more familiar with it and becoming more comfortable with it, because in our daily lives, we're surrounded by it, right? Whether you're going online and doing shopping, whether you're talking to your Alexa or to Siri, or you're using Google Maps. I mean, you're seeing this in your private lives. And now, as it starts creeping into clinical medicine, it may be that we may be a little bit more comfortable using that on the clinical medicine side as well, which may slowly, maybe I think, increase the pace of breaking down that other barrier. One of the other barriers for this, which is clinicians don't trust AI, and maybe we trust it more in our private lives, we may start trusting it more in our work lives. Whether that's a good thing or not, I think we'll probably talk more about that.
Yeah, and so much of this is, clinicians don't trust AI, but I think a lot of clinicians who are normal human beings outside of their day job don't realize how much AI is already in their normal lives. This is not hidden, but we're going on vacation in a couple of weeks, and use that GPT to, hey, can you plan that itinerary for me to start, and I'll go from there. Speaking of the GPT, which are the algorithms that use deep learning and a large database of training text to generate new text, so this generative AI that you've already referenced. Have you used these in your clinical practice at all? Or do you know any colleagues that have used these? Any experience with this?
Yeah, so there has been some survey work on this, and it looks like around, up to 40% of clinicians have used these tools in their practice at least once. A lot less than that use it every week or, on certainly on every patient. But I think that one of the more common uses of it is, drug interactions or helping to identify, literature to support or, certain differential diagnoses or even treatments. So I think clinicians are using them and asking, questions of these large language models. And, I think my initial reaction when I first started using them was a mix of sort of excitement and horror at the same time. I think it was really exciting to see, how eloquently and how structured and how believable all the text seemed and how human-like some of the results were. At the same time, you could see instances where it was making up references or getting two concepts that sound similar mixed up, and then the results were nonsense. And if you just blindly trusted the algorithm, you could be led in a wrong direction that could potentially harm patients. So I think we're going to see these being used by clinicians in a lot of different ways at the bedside, and they're going to continue to get better. But I think, which is why I think we need to learn how to use them and when to use them, I think is a really important point.
Yeah. I mean, this may not be necessarily your area of expertise or something you feel the best to comment on. Do you have any advice or caution for providers who are looking to start to use it or have been using it for a little bit now, ever since this GPT boom in the past couple of years?
Yeah, I think you really need to treat these like an inexperienced trainee, right? So in other words, when you're interacting with these models, you shouldn't be treating them like an expert clinician. Or a subspecialty, certainly not a subspecialist expert clinician, right? You should do the things you would do if you had a new medical student come to you with their differential diagnosis and they see the fever and they're talking about how malaria is on the differential, right?
Because it is.
It is. It should be, right? But I think what you need to do is you need to make sure that you have you're using your own clinical judgment. And the other thing that I think is really important is this day and age, you can actually ask it for references. And in some of the applications will provide references automatically. And I would look into those references because sometimes you look at those references and you realize that, yeah, actually, this is exactly the paper I'm looking for. Here is the European Society's guideline on this very disease that I couldn't find when I was Googling earlier. But sometimes it will show you a source that has nothing at all to do with the topic that you're asked about. And so I really think that if you look at it like an inexperienced trainee where you're verifying everything that is providing you, and you also have a sense of what things you could ask it to do that you can trust it on, and what things you can ask it to do that maybe you really need to look closer on. You talked about your itinerary for your trip, right? And I think that, as an example, like if I want to go to X restaurant after work today, I'm probably just going to plug it into Google Maps and I'm just going to let it drive me to that restaurant or follow the directions to the restaurant. And I have a very low concern that it's going to drive me off a cliff somewhere because it doesn't know where the roads are. Right. Whereas if I'm going to, we're going to Greece this summer on vacation, and I did use it somewhat to help plan the vacation, but I'm not going to show up at the airport without looking at any of the results and just saying, take me wherever the AI told me to go and I'll be back in 2 weeks, right? So I think the human has to be in the loop somewhere. And in medicine, I think we need to be in the loop early and often to make sure that these are safe recommendations.
Yeah, no, I think that's a really good point, and certainly reassuring to patients and people who are receiving care to say, hey, we're using this as a guide, but we're still kind of behind the scenes and making everything safe and good for our patients. But this is all great. We're going to take a short break, and then when we return, we'll talk a little bit about your current work, Matt. We'll be right back.
The ATS 2025 International Conference returns to San Francisco, May 16th to the 21st. Members get a discount on conference registration, so become an ATS member or renew your membership to take advantage of these savings. At ATS 2025, you can network with colleagues, find your next research collaborator, listen to patient stories, and get inspired. and be among the first to learn about breaking news in pulmonary medicine. Register now to attend. Go to conference.thoracic.org today.
All right, everyone, welcome back. We left off talking about some anecdotal experience using AI in clinical practice. Matt, your research focuses on a different flavor of AI, where you develop models that may be able to guide the clinician in the optimal care of those patients. Can you tell me a little bit more about that?
Yeah, so as I mentioned earlier in my career, I focused on just identifying who was going to develop critical illness. But at that point, I think it's one thing to get to the bedside of the patient, but what actually is going to improve the care is providing the treatment that for that patient has the highest likelihood of improving their outcome. And so, when we look at especially in critical care at the evidence-based medicine that we have, what we are seeing are these trials that are completed, and they're presenting the average treatment effect across all the patients in the study. But you might imagine that within that study, there may be some patients likely who were harmed, and maybe quite a bit, by the therapy, and other patients who may have benefited from that therapy. And so, so this whole idea of, well, can you identify who those patients are? Can you use machine learning, for example, as an approach to predict the degree of benefit or the degree of harm for an individual patient? Because if you can combine this idea of evidence-based medicine from randomized clinical trials with what we're calling, what the field calls causal machine learning, in other words, trying to understand and essentially try to predict causal effects for individual patients, we can get closer to personalized medicine for the patients in front of us. And so with that in mind, our research group, in collaboration from, a number of, Matt Semler from Vanderbilt and Paul Young and, many others, we've been collaborating on these clinical trials and using these machine learning algorithms to try to identify the patients who are benefiting and who are being harmed by therapy. And the goal is that in the future, for an individual patient, even if the average treatment effect from a trial said that there's no difference, for that individual patient, we can provide them the therapy that is predicted to benefit, or avoid therapies they were predicted to be harmed by.
This is really interesting to me, and it reminds me of a comic. I guess I was reading this. Should give a little insight of what kind of comics I read. But just saying, hey, like the point was that the individual patient that you're taking care of when you're seeing patients in clinic, you're seeing patients in ICU, is they're not interested in the trial. They're not interested in what happened to those patients, to patients like me. They want to know what's the best treatment option for me. And to be quite frank, I as a patient am also interested in that. I'm interested in what's best for me as an individual, which may not be the same as someone who comes up with similar statistics or a similar chart who might be next door.
Right. Exactly. And so I think that in some ways in critical care we have a lot of negative trials, right? And I think
too many, right?
Yeah, too many, right? And so it may be that these are truly studies where no one is benefiting and no one is being harmed. There's just no effect at all. But I think it's our hypothesis that at least in some of these trials, those null effects or the non-significant average treatment effects are because of the fact that there are some patients who are benefiting from the intervention and some are being harmed. And so, for example, last year we published a study on oxygen targets where we developed these causal machine learning models in the pilot randomized controlled trial in the US, and then validated the model in the ICU ROCKS trial in Australia, New Zealand. And even though these two trials didn't find a significant average treatment effect, we found quite a variability in the individualized treatment effects in the ICU ROCKS trial, suggesting there were a lot of patients who would have potentially benefited from a high target or a low target. And so in the future, I think what we need to do then is if we can identify situations where there are there is this heterogeneity of treatment effect. And then we can validate that these models are working well in external and additional trials. We can then start testing these models against usual care to see, can these models provide useful guidance to clinicians that will optimize the care and the outcomes of patients beyond what we're currently doing? So I think it's another way of thinking about machine learning, in that not only can we target who is at risk of dying, but hopefully we can also provide useful recommendations regarding, well, what can help prevent that?
Yeah, no, I mean, this is really fascinating work, and certainly, as you had already referenced, this is your ongoing work, and it's very excited to see where that's going. We've talked a little bit about early warning signs. We've talked a little bit about this idea of personalized medicine, which I think a lot of people are really excited about. We talked about some of the GPT learning stuff. Are there any other clinical applications of AI that you've heard of that we haven't touched upon already? I mean, I know some of my colleagues are really excited about AI-based scribes for note writing, which I guess in a lot of senses is not directly impactful to patient care, but does impact clinical practice.
Right. I mean, I think if we look to the different applications of AI in medicine, there are, as you were talking about, there are some applications that are not patient facing, but I think are still going to be really important, right? I think whether it's algorithms to help improve the quality of coding on an operations side for revenue generation, or at least coding accuracy, for example, to one of the projects that we worked on here at the University of Wisconsin was, clinicians get a lot of in-basket messages. And so we just published a paper where we essentially used, a GPT model to help draft responses to those messages. And then the clinicians would then read the response and then edit the response and then be able to send it out. Similarly with scribes, you can have these devices that are listening to your conversations with the patient and then helping to draft your note, and potentially providing additional useful information. So I think there are then this other category of things where the goal could be to improve the efficiency of the work we do, and I think those have a great potential to improve our quality of life and help with burnout potentially. Now, I know for decades and decades, it's like, oh, the electronic health record is going to help with burnout. And then, of course, it's not
exact opposite.
Done the opposite. But I my hope is that one day AI or big data or whatever you want to call it is really going to help tackle that problem. And I think, helping with note writing, scribes, those things can help with that piece of it. And then I think that another part of it, which where these models are being used, is in education. So in similar surveys that I mentioned earlier, medical students are using these tools quite a bit to help with their education. And I think that there are, a number of groups around the country that are using these approaches, generative AI, for example, to help with simulation training, developing patient cases, or other ways to help with education and training, which can directly help, help with patient care. So I think in addition to, some of the direct patient-facing activities, I think there's a number of other ways that it overall could help us as clinicians, as well as help patients, in addition to, some of the models that are directly kind of predicting or recommending treatment for patients.
Yeah, I mean, I think that both of those statements ring really true for me. I'm not that old, but when I was in grade school, I learned how to Google things, right? Like now it's second nature to everybody, and pretty soon, children and teenagers and grade school children are going to learn how to use AI and how to answer questions and search for information and get there. And eventually, those children are going to grow, and some of them are going to become physicians. And so these are going to be kind of a real part of kind of the growing education landscape. And then when you're talking about the kind of efficiency and burnout, I think it's going to be hard to fully tease out its individual effect, but this will, I think, have a downstream impact on patient care. If we're able to focus more of our energy on the care of patients rather than the documentation and other clerical burdens, I think that's only going to be a good thing, I think, overall for patients downstream.
Yeah, and I think that, folks who are really excited about AI and talk about how, it will help make you more efficient. And of course, then the response is, well, that means I'm just going to get more patients added onto my clinic.
Yeah.
But at the same time, I think that, I think most of us, maybe all of us, went into medicine because we wanted to care for patients and not write a bunch of stuff down and do a lot of documentation and do a lot of things for billing, right? So if I had to choose between seeing, I don't have a clinic, so I'm making up numbers here. But if I had to choose between seeing 10 patients in a day, but then spending a lot of my hours, writing a lot of documentation and doing other things that could be automated by AI, or seeing, 15 patients in a day, and all of that is like face-to-face talking with the patient and making that relationship with the patient, I take the latter every day as long as I get more time doing, the things that got me into medicine in the first place.
Yeah, I mean, no medical student wrote their personal statement about how I wish I could spend more time at a computer, right?
Yeah, that's right. Maybe they will in the future. I don't know, but
maybe. But as of right now, I think that's true. At least it's true for you and I. So Matt, I guess I'll take you a little bit back to your research, and maybe you can answer this question in two ways for you personally in your research, and then also in general. What's coming next in this field for us as clinicians? Where do you want to see this field move?
Yeah, so I think what's coming next and where do I want to see it move are probably two sort of highly interrelated questions here. So I think what's coming next is that I think the models are going to get better and better and better. I think imagine where we were 2 or 3 years ago now versus where we are now. It's really been an incredible leap forward. And, so I'm imagining that the models themselves are going to continue to improve. I think that there is a lot of drive to try to get these models to be more transparent, to provide more citations, to have more guardrails as it relates to models that might be, implemented in a patient-facing manner. So I think that there's going to be a lot of growth in that direction. I also, because of the fact that a lot of big industries, big tech, EHR companies, there's a lot of funding, a lot of resources, a lot of money in this area. I think the field is going to move, a lot faster than what we typically think of in academic medicine, where you write a paper and 10 years later it becomes part of a guideline and people actually start doing it. I think we're going to see things change and move a lot more quickly. I think that in addition, we're going to see models that can use multimodal data that are being integrated into the EHR, where you're able to utilize the clinical notes, the structured data, the image data. And so you're going to be able to get a fuller picture of what's going on with the patient as well. And I think that from a technical perspective, one of the things that you're seeing a lot now is this idea of agents and multi-agent workflows. So I think, what does that mean? I think, so what an agent essentially does is it allows, when you give it a task, it will plan the task, it can interact with the environment, it can then sort of reiterate, sort of optimizing that task, and then you can interact with it, and it sort of has a memory of that conversation you've had with it before. So, a year or two ago, these models often were static models that were trained on data up to a certain point. And so it would provide you information, but unless it was explicitly programmed to look at the internet, it may forget. It may not know that, travel to that country is closed, so you can't go there. Or, this airline is no longer flying out of this city or whatever else, right? So, but now you can develop these agents that can develop expertise and interact with the environment. So how might that work in the EHR? Well, you could, for example, have an agent that focuses on, tries to become, a radiologist and interacts with the radiology images and really essentially gains expertise in reading the radiology images in your center. And then you have a critical care physician agent that then talks to the radiology agent, where the critical care physician agent is learning about all the other clinical data about the patient and maybe knows the guidelines and those things. And then all these agents start interacting and then providing sort of final recommendations, or you can continue to interact with them over time. So I think way down the road, we're going to be able to have these essentially, whether you want to call them, assistants or guides or agents that are able to summarize information and even, provide additional even recommendations for things that you might want to do. So I think that's where we're going over the long term. I think the hurdles to that are many. I think there are obviously patient privacy concerns about these. I think that's always a hurdle for these types of models. I think there are cultural changes in terms of trusting these models. And I think another hurdle is that it's really hard to evaluate the quality of these models. If you're developing a classification model, you can output an AUC. And and then you say that 0.9 AUC, that sounds really good. Okay, that's a good model. And this other model, the 0.4, 0.5 AUC is not better than a coin flip.
Yeah, you have these numbers that tell you that the model is good or bad, and that's pretty easy.
Yep, exactly. And so I think another challenge with this is that it's difficult to, at scale, evaluate these models when they're outputting a lot of text. And so how do you know, if you want to implement one of these models in your practice, how do you know if it's which model you use? And how do you know if this is a good model or not a good model? How are you going to evaluate that? And I think that becomes a challenge if you're trying to get it to do board exam questions and answers, that's an easy evaluation because they're multiple choice. But for clinical medicine, it's a lot more complex.
Yeah. Are these the things that you had referenced a little earlier when I asked the original question, that where we're going and what you're excited about and where you want to see that things move might be a little bit different? Are these agents things or the things that kind of make you excited, or what for you in your research, where are you thinking the next steps are going to be?
Yeah. So in terms of like where I really want this to go, I think that I think a really important part of this is making sure we're evaluating these tools and testing them in clinical studies, especially things that are going to drive clinician decision-making and clinician actions in really rigorous ways, right? Because I think that there is a lot of excitement to just build these models into the EHR, turn them on, let clinicians use them because they have to be helpful, right?
Obviously.
But I mean, how many times, again, if we go back to critical care, right? I mean, how many times we said, oh, this is, all the data shows this is clearly going to be the intervention that's going to help patients. And then we find that it's actually the opposite, right? So, I think we really need to consider these as we would consider any other intervention, in that we need to be having rigorous studies comparing how these models are being used to whether it's usual care, standard of care, whatever you want that control group to be, and making sure that not only are these valuable and providing benefit to the clinicians or the provider, and or the patients, and hopefully both. And then there's also the costs involved, and then there's also things like health equity and making sure that these models are trained on biased data that are available, on the internet. And oftentimes you don't know what all data sets were used to train these models. And you could, I think there's always a concern that maybe you could be reinforcing some of the biases that are already inherent in medicine by using these models to care for patients as well. So I think there are a lot of guardrails. There are a lot of things that we really need to be implementing, and a lot of things we need to be investigating before we just turn on a bunch of these and let them go wild in clinical medicine.
Yeah, I think it's really refreshing for me, and I think I'm sure many of our listeners, to hear from someone whose research is in this field and this field is exploding, to express this desire to, hey, like, we need to pump the brakes a little bit. We need to make sure what we're doing is the right thing. Nobody ever made a decision or tried to make a change that they thought was harmful. Everybody's always trying to do the right thing, but we have to make sure that we're doing the right thing for our patients overall.
Yeah, exactly.
I think that's probably a pretty good note to start to wrap up. Is there anything else that you think our listeners would be interested in, or any other last words that you wanted to part on us?
Yeah, I mean, I think that I think we're living in a really exciting time for medicine, and I think, I don't want to leave on a downer. So I really do think that these AI and machine learning, and certainly these new generative AI tools and models, I have great potential to improve our lives as clinicians and the lives of our patients. I think we need to think about, how do we want to help drive the use of these? How can we identify the best use cases? How can we sort of drive this field? Because I don't think we as clinicians want to be passive observers and let the big tech companies decide, how these are going to be implemented in clinical practice. I think we really need to try to advocate for the concerns that we have about these models, the needs we have for these models, the needs our patients have for better care, and then to see how can we then implement these models to solve these problems. And so I really hope that's where we move into the future, and I'm really excited to see where everything goes.
Yeah, no, I think that's great. It's never a downer talking with you, Matt. I really do appreciate your time. Thank you, Matt, and thank you everybody for listening, for joining us on today's ATS Breathe Easy episode. Please subscribe and share this episode with your colleagues. If you haven't done so yet, register for the ATS International Conference, San Francisco, and conference.thoracic.org. Members get a discount conference registration. It'll probably be on the later side now, but we will see you next time. Thank you all.
Thank you very much.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more ATS Breathe Easy podcasts on Transistor, YouTube, Apple Podcasts, and Spotify. Don't forget to like, comment, and subscribe so you never miss a show.